I am waiting here. I started streaming. I am started streaming. Oh. Yes, good evening. Good evening, all of you. Very good evening once again. Welcome to today live discussion on MCQs from the pharmacology subject. And the topics we are going to discuss about MCQs. So, drugs acting on peripheral nervous system, drugs acting on kidney, and gastrointestinal drugs. I hope you are very serious and you are very busy in your GPAT preparation. That's true. But already this is a December. So with today, 1 week also completed in the December. And with December, still only 5 months are left for upcoming GPAT 2026 exam. Okay, if after that April, if days are left, that's good. But psychologically, fix your brain. Okay, from now onwards, April only the target. After April, we are ready for the exam. If once April is ending, you are ready for your GPAT exam. So for that purpose, you know that always already you choose the GDC platform. You are from Hindi platform or English platform. That's good. Not a problem. Only language is the barrier. If you are really from the South Indian region, prefer the GDC English classes to make comfortable regarding the language. And fix that, come to the class daily, and after completion of classes, revise by using the recorded lecture available in our app. And after that, if you having perfect knowledge, grip on the subject, particular topic, go and practice the MCQs. After practicing MCQs also, again come and revise the same topic. So follow this daily. Definitely, you will easily crack the GPAT exam 2026. Not only cracking and qualifying, definitely you will get a top rank, that is sure, because everything, every time and every years since 15 years, the same tradition is continuing in GDC, because GDC is like that platform. We are providing everything, but it's up to you. You are ready to receiving or not. So still only 5 months are left. Very very serious about your preparation and come to our classes, follow our live classes, everything etc etc. and make more powerful towards your examination in the point of preparation. Okay. Anyway, let's go into the discussion with first MCQ. So what is the first MCQ is here? The first MCQ is which of the following sets includes only aggressive factors in peptic ulcer disease? Like in the epilepsy, there is a domination of aspartate glutamate excited neurotransmission and decreasing inhibitory neurotransmission develop epilepsy. In the peptic ulcer also there is a defensive factors, aggressive factors. Aggressive factors like HCl increase the peptic ulcer, and defensive factors like prostaglandins and mucus production, they decrease the risk of peptic ulcer. So, which of the following factors comes under the aggressive factors regarding the peptic ulcer? So, option A, pepsin, mucus, mucus, acid, bicarbonate, acid, NSAIDs, acid, pepsin, H. pylori, alcohol, mucus, NSAID. So, simply acid, HCl, pepsin, nothing but promote the HCl production, and Helicobacter pylori. So these are three are the factors. They are aggressive factors. They increase the risk of peptic ulcer by increasing the damage of gastric epithelium. Gastric epithelium. The simple answer is option C. So here is a simple. So peptic ulcer is break in the inner lining of the stomach, nothing but peptic ulcer, and aggressive factors like acid, pepsin, NSAIDs, and H. pylori. Defensive factors like mucus, bicarbonate, prostaglandins, and excess use of alcohol, tea, coffee also may develop the peptic ulcer, because excess intake of caffeine increases cyclic KMP production in the GIT. Increasing cyclic KMP production in the GIT increase the risk of ulcer by increasing HCl production. So that is clear regarding the first MCQ. The aggressive factors are acid, pepsin, as well as H. pylori. Next question. The following drug has both anti-emetic and prokinetic. Anti-emetic, reduce the vomiting, control the vomiting. And prokinetic, improve the movement of GIT, increase the movement of GIT, prokinetics. So, hyoscine anticholinergic, metoclopramide, dimenhydrinate, as well as chlorpromazine. Chlorpromazine is a antipsychotic. Dimenhydrinate is like an antihistamine. And coming to metoclopramide, having anti-emetic property with as well as prokinetic properties. So prokinetics, nothing but they helps in to promote, to increase gastric movements. So answer is simply metoclopramide. Answer is metoclopramide. So simply it is a anti-emetic work by preventing vomiting, especially by blocking type 2 dopamine receptors in the central nervous system, especially CTJ. And especially this drug reduces nausea as well as vomiting. And prokinetic increases stomach and intestinal movements. They increase stomach and intestinal movement. Especially they increases intestinal movements by stimulating the type 4 serotonin receptors. Next. So these questions are very, very important. If you are answering like these questions, you are in a right track. For example, GPAT is like a war. If you want to win a war, you should be participate in the war. So without sacrifices, without putting your efforts, nothing will easy to come towards you. So next, so for example, here column 1, here column 2. So H2 antihistamine. So generally H2 blockers are ranitidine. Proton pump inhibitors like omeprazole. Ulcer protectives, sucralfate. Sucralfate forms a sugar polymer like coat on ulcer layer and protects the ulcer from the damage. And anti-H. pylori drug, so like a clarithromycin. Clarithromycin is an antibiotic. It having antibacterial activity on the H. pylori. Helicobacter pylori is one of the type of gram-negative bacterium. It is one of the type of gram-negative bacterium. Easily can effectively nothing but increase the risk of H. pylori ulcer. Okay. So according to this, already I matched here. So according to this, the answer is the option A. That is P. P is ranitidine, and Q is omeprazole, and ulcer protective sucralfate, and S anti-H. pylori is a clarithromycin. So clarithromycin comes under macrolide antibiotic. It comes under macrolide antibiotic. So that is very simple, the answer. Next question. So nothing but this is the classification of anti-ulcer drugs, especially in the treatment of peptic ulcer. So classifications are very, very important. Directly or indirectly, you will get nearly 5 questions from the classifications point of view in the pharmacology university GPAT examination. Next, which PPI is the which proton pump inhibitor is the safest in pregnant women and has high oral bioavailability? So omeprazole, lansoprazole, S-omeprazole, pantoprazole, all these are proton pump inhibitors, and S-omeprazole is a S isomer of omeprazole, S-omeprazole. And here answer is the lansoprazole is regarded as a safest in pregnant women as well as it having high oral bioavailability with less first pass metabolism. The less first pass metabolism. So that is a simple answer. So proton pump inhibitor, what they are doing, they specifically inhibit H plus potassium ATPase enzyme and decrease production of acid into the GIT wall, gastric wall, and reduce the risk of peptic ulcer. So lansoprazole is the safest in pregnant women. Next question. So a patient undergoing cancer chemotherapy gets ondansetron for prophylaxis of drug-induced nausea and vomiting. Which of the following best describes this drug's main mechanism of action? This drug's main mechanism of action. So, for example, here ondansetron is common drug, selectively blocks type 2 serotonin 3 receptors in the CTZ, chemoreceptor trigger zone. By blocking serotonin type 3 receptors here, they helps in treatment of vomiting. So because of that mechanism, what these drugs are doing? Blocks central serotonin type 3 receptors. So serotonin type 3 receptors are ion channel or ionotropic receptors. Comes under the nothing but they are also known as fast acting receptors. There are 7 types of serotonin receptors. Among 7 types, serotonin type 3 only ion channel or ionotropic receptors. Ion channel or ionotropic receptors. Okay, just a minute. So here the clear answer is the option B. Next question. Which statement regarding proton pump inhibitors is true? They are active at the neutral pH? No. They become active in the acidic pH less than 5, forms active moieties like sulfenic acid, sulfonamide. So when proton pump inhibitors enter into the GIT, they converts to active form like sulfonic acid and sulfonamide. They directly block H receptors? No. Food decreases their viability? No. Here the answer is they require less than 5 pH to convert to active form like sulfonic acid and sulfonamide, which are effectively inhibit the H plus potassium ATPase enzyme and helps in the treatment of peptic ulcer effectively. Answer is simply option B. Option B. Simple logic. Okay. Next question. Regarding the next question, magnesium trisilicate is considered better than aluminum hydroxide because so both magnesium trisilicate, aluminum hydroxide are antacids. Sodium preparations of antacids are systemic in nature. Okay, and here so what is the difference between has higher ANC and forms colloidal silicon dioxide, causes less drug interaction, is systemically absorbed. So answer is simply they forms a colloidal silicon dioxide. That is the difference between magnesium trisilicate and aluminum trioxide. Aluminum trioxide. Answer is very simple. Option B is the answer. So here difference between the non-systemic antacids and the systemic antacids. So systemic antacids are simply sodium salts of antacids, and remaining are aluminum salts, magnesium salts are they are non-systemic antacids. They are non-systemic antacids. Next, Which of the following antibiotics is not commonly used in H. pylori eradication therapy? Which of the following antibiotics not used in eradication, removing of H. pylori? So, amoxicillin, penicillin antibiotic, clarithromycin, a macrolide, ciprofloxacin, a fluoroquinolone, metronidazole, a anti-protozoal, nothing but anti-amoebic drug. So, among these, ciprofloxacin fluoroquinolone is not a part of treatment of H. pylori from the antibiotics point of view. From the antibiotics point of view. Okay, the answer is simply ciprofloxacin. Next, so that is a anti-Helicobacter pylori drugs. These are the list of the drugs. So H. pylori is a gram-negative organism. It effectively causes peptic ulcer. Next, side effects of colloidal bismuth substrate include the side effects like constipation, blackening of tongue and stool, maybe leads to bismuth toxicity, diarrhea, hypercalcemia. Simply, excess usage of this colloidal bismuth substrate, it causes blackening of tongue, blackening of stools, and may lead to toxicity of the bismuth salts. Toxicity of the bismuth salt. The question is simple and the answer is also very simple. Especially the bismuth salts are having antibacterial effect on the H. pylori. Next, GERD. In short, it is known as GERD. 𝘂𝙬𝙎𝙎 syndrome is associated with elevated levels of CCK, cholecystokinin, gastrin, secretin, as well as VIP, nothing but vasoactive intestinal peptide. Especially excess levels of gastrin may form tumors of the gastric glands that are also known as 𝘂𝙬𝙎𝙎 syndrome. 𝘂𝙬𝙎𝙎 syndrome. The answer is simply gastrin. This condition is characterized by tumor of gastrin, increases excess production of gastrin, leads to excess HCl production and development of peptic ulcers. This is the explanation regarding the 𝘂𝙬𝙎𝙎 syndrome, why it is happening, what are the things you can observe in case of this 𝘂𝙬𝙎𝙎 syndrome. It is mainly characterized by tumors of the gastric glands. Next, again the matching the following. Next question. So simply, column 1, peptic ulcer disease, 𝘂𝙬𝙎𝙎 syndrome, GERD, gastroesophageal reflux disease. Sometimes the gastric content may reflex back to the esophagus because of that there is a painfulness at the esophagus. Gastroesophageal reflux disease and NSAID induced ulcer. So regarding treatment of peptic ulcer, generally omeprazole will be useful. 𝘂𝙬𝙎𝙎 syndrome, which one will be useful? Regarding antacids will be useful, and GERD gastroesophageal reflux disease. Okay, and NSAID induced ulcer generally misoprostol will be preferable. So here the answer is simply option D is the answer. So P, peptic ulcer, omeprazole will be useful, and 𝘂𝙬𝙎𝙎 syndrome, ranitidine, H2 blockers will be useful, and R, GERD, antacids will be useful. Gastroesophageal reflux disease, antacids will be useful, and S, so NSAID induced ulcer, misoprostol. Sometimes in the matching, the advantage is if you observe NSAID induced ulcer. NSAID is like aspirin, paracetamol, aceclofenac, diclofenac. They interfere with the prostaglandin synthesis in the GIT and causes deficiency of prostaglandins in the GIT and develops a ulcer. NSAID induced ulcer. So here in NSAID induced ulcer, misoprostol, a prostaglandin derivative, is used to control this NSAID induced ulcer. So here NSAID induced ulcer, answer is misoprostol. So here S2. So S2 is present only in the option D. So sometimes like this, if you know exact answer of one thing also, you can easily answer the options. I hope you're getting my point. So here answer is the option D. Next. Which of the following combination is most likely used to minimize the gastrointestinal side effects of magnesium hydroxide? Which of the following combination is most likely used to minimize the gastrointestinal side effects of magnesium hydroxide. Magnesium hydroxide plus aluminum hydroxide, magnesium hydroxide plus omeprazole, magnesium hydroxide plus sucralfate, magnesium hydroxide plus ranitidine. So combination of magnesium and aluminum salts are effective because magnesium salts alone cause diarrhea, aluminum salts alone cause constipation. So combination of both with decreasing the doses neutralizing affects each other. So magnesium sulfate, magnesium MgD, magnesium cause diarrhea, aluminum AlC, aluminum cause constipation individually, but combination neutralize the both effects. That's why both are combined for effectively controlling the side effects like diarrhea as well as constipation. Diarrhea as well as constipation. Answer is option A. So magnesium hydroxide osmotic diarrhea and aluminum causes constipation, but both may cause a neutralization of each effects. Neutralization of each effects. Next, which prokinetic drug acts primarily by dopamine D2 receptor antagonism and also enhances gastric emptying like prokinetic. So blocking D2 receptors as well as promoting the gastric movements like metoclopramide, domperidone, cisapride, erythromycin. Okay, so the same question in different manner we already saw. The answer is simply metoclopramide. Metoclopramide blocking D2 receptor control nausea and vomiting and also promote the gastric emptying, increase the gastric movements by stimulation of serotonin type 4 receptors in the GIT. The answer is very simply metoclopramide. This is the explanation of this MCQ. Next, which prokinetic drug does not cross the blood-brain barrier, minimizing the CNS side effects? So, because of one of the drug not easily cross the blood-brain barrier, so if it is not entering to CNS, there is a less chance of CNS side effects or no CNS side effects. So, metoclopramide, domperidone, cisapride, erythromycin. Okay. So, here the simple answer is like dopamine, domperidone. Domperidone does not easily cross the blood-brain barrier and it is having less central nervous system side effects. Less central nervous system side effect. Simple answer. This is the explanation. So it is a peripheral domperidone. Dom nothing but dopamine and it selectively acts on the peripheral dopamine receptors, not on the central dopamine receptors. Not on the central dopamine receptors. Next question. So, which of the following statements are true regarding sulfasalazine and 5-amino salicylic acid? Sulfasalazine and 5-amino salicylic acid. 5-amino salicylic acid is a first-line drug for mild moderate ulcerative colitis. Ulcerative colitis is a part of inflammatory bowel disease. 5-amino salicylic acid is good for treatment of this ulcerative colitis. So, inflammation of the colon characterized by ulcers, ulcerative colitis. Sulfasalazine prevents early absorption of 5-amino salicylic acid. Early absorption of 5-amino salicylic acid reduces its efficacy in colon inflammation. Sulfapyridine is the main active moiety responsible for the anti-inflammatory action. So generally if you observe, sulfapyridine is an antibacterial and 5-amino salicylic acid is anti-inflammatory. So sulfapyridine is the main active moiety responsible for anti-inflammatory means no, this is the wrong. Yes is the wrong. Sulfapyridine is a sulfonamide-like drug. It having antibacterial property. 5-amino salicylic acid having anti-inflammatory. So choose the correct pair. So you know that clearly S is wrong. So S is present in the D and present in the C, present in the B. So PQR is the correct. PQR is under the option A. Under the option A. The answer is very clear. Option A is the answer. Next. So here sulfasalazine is a product. Once it enters into the body, it converts to 5-amino salicylic acid anti-inflammatory and sulfapyridine antibacterial. Effectively helps in the treatment of inflammatory bowel disease, a combination of inflammation, infection, and also characterized by autoimmune disease, inflammatory bowel disease (IBD). Next. Identify the diuretic which causes hyperuricemia, raises serum calcium, and causes magnesium depletion. Identify the diuretic. Which of the following diuretic it is causing hyperuricemia, increasing uric acid levels in the blood, raises serum calcium, increasing calcium in the serum, and also causing depletion of magnesium in the body. So acetazolamide, furosemide, mannitol, chlorothiazide. So loop diuretics are the drugs. Loop diuretics are the drugs. They increase the uric acid levels and they reduce calcium in the blood as well as in the magnesium. Reduce both calcium and magnesium and increase uric acid levels in the blood. Sorry, sorry for inconvenience. So that is chlorothiazide, not furosemide. Hyperuricemia increases uric acid levels in the blood and also raises serum calcium. So drugs like chlorothiazide, like thiazide diuretics. Thiazide diuretics, they increases calcium in the blood and they known as calcium storing drugs, calcium sparing drugs. But loop diuretics are calcium wasting drugs. Loop diuretics increases excretion of calcium through the urine, but thiazide diuretics increase the levels of calcium in the body by reducing excretion through the urine. So thiazide diuretics are calcium sparing and the loop diuretics are calcium wasting. The answer is chlorothiazide, that is thiazide diuretic. Sorry for small inconvenience. So this is regarding thiazide diuretics and their general side effects. Next, the primary molecular target for furosemide in the nephron is the primary molecular target for furosemide in the nephron. Sodium potassium ATPase at thick ascending limb of 𝘂𝙀𝙎𝙾, sodium chloride cotransporter at DCT, sodium potassium 2 chloride cotransporter at luminal membrane of the thick ascending limb of 𝘂𝙀𝙎 and at collecting ducts. So simply the answer is furosemide is a loop diuretic, also known as high ceiling diuretic. They specifically acts by inhibiting sodium potassium 2 chloride transporter. Sodium potassium 2 chloride transporter. That is the simple answer of mechanism of furosemide natrimeter loop diuretics. Mechanism of furosemide natrimeter loop diuretics. Okay. Next question. So here, high ceiling diuretics are preferred over thiazides in treatment of CHF mainly for high ceiling diuretics, nothing but loop diuretics like furosemide. They are preferred over the thiazide diuretics in treatment of congestive heart failure because of long duration of action, rapid mobilization of edema fluid, better potassium retention, antihypertensive effect. The answer is simply option B. Loop diuretics are high ceiling diuretics, high efficacious drugs as a diuretics because they efficiently increase the filtration and efficiently remove the excess fluids from the body and controls the edema. If body fluids are eliminating easily, automatically excess fluids reduces in the body, edema control as well as hypertension also control. Congestive heart failure nothing but excess accumulation of fluids in the heart. Heart is unable to work properly due to excess congestion of fluids in the body. Sorry, heart, congestive heart failure. Why? Loop diuretics, nothing but high ceiling diuretics are furosemide is preferring because of rapid mobilization of edema fluids from inside of the body to outside of the body through effectively increasing glomerular filtration rate. So answer is option B and this is a clear explanation. Next, the following not true for furosemide: causes hypokalemia, causes hypouricemia, ototoxicity, acts by inhibiting the sodium reabsorption. So generally drugs like diuretics, they increases secretion of sodium through the urine, but here they are mentioning it acts by inhibiting sodium reabsorption. Yes, simply inhibiting the sodium reabsorption means eliminating the sodium. Loop diuretics causes ototoxicity and loop diuretics causes generally hyperuricemia, excess uric acid in the blood, and they cause hypokalemia. Hypokalemia is true. Thiazide diuretics, loop diuretics causes hypokalemia. They less, they cause decreased potassium in the blood. The answer is very simple. Which is not true is option B, because loop diuretics causes hyperuricemia. They increases uric acid in the blood. These are the adverse effects of furosemide. Next question. What is the normal glomerular filtration rate? Simply 120 ml per minute, 140 ml per minute, 240 ml per minute, 120 ml per hour. So hour, remove the option D. And 240 ml, no. 140 ml, no. 120 ml. 120 ml is the average GFR value per minute. The answer is very simple because the question is also very simple. Option A is the answer. This is the discussion. Okay. Next question. This is a little bit tricky, so let's have a discussion. DM is a 62-year-old African American man who has had poorly controlled hypertension for the past 10 years and now presents with the signs of ankle edema, a low GFR and a serum creatinine of 2.5 mg per deciliter. The most effective drug for producing a diuresis and a fall in blood pressure in this. Okay, fall in this blood pressure. Generally, amlodipine is a calcium channel blocker. Itself can produce ankle edema as a side effect. Next, furosemide, hydrochlorothiazide, losartan. So coming back to the basics, loop diuretics are high ceiling diuretics. They protect person effectively by increasing the elimination of excess fluids from the body like diuretic action. So furosemide is a loop diuretic, also known as high ceiling diuretics, effectively help in this condition to effectively increase the expression of fluids from the body through urine and reduce the excess fluids in the body and reduce the plasma volume. Answer is very simple. Furosemide, a loop diuretic, highly efficacious diuretic. High efficacy diuretics. High efficacy diuretics. Next question. Drug of choice for central diabetes insipidus. Diabetes insipidus, urine volume is more, but the urine is a diluted urine, not concentrated urine. So drugs like vasopressin, desmopressin, lipressin, presilin, all these are derivatives of ADH, nothing but vasopressin. But desmopressin is the analog of vasopressin, effectively help in the treatment of diabetes insipidus interlinked with the central nervous system. Central diabetes insipidus. The answer is very clear. Desmopressin. Vasopressin itself a ADH derivative, nothing but vasopressin itself present in the body, but it having short half-life. It derivative desmopressin having long half-life compared to vasopressin. So this is an explanation. Next question. 𝙂𝙃 acid is not used due to renal toxicity, ototoxicity, GI toxicity, pulmonary toxicity. So 𝙂𝙃 acid is comes under loop diuretic. It is effective drug in the initial days of loop diuretics enter into the market, but 𝙂𝙃 acid is having severe ototoxicity. Nowadays it is not preferring because of this toxicity. That is option B is the answer. Okay. Next question. Choose the correct uses of acetazolamide, glaucoma, mountain sickness, epilepsy. So, acetazolamide is a carbonic anhydrase inhibitor. Acetazolamide is a carbonic anhydrase inhibitor, comes under the class of diuretics. It helps in treatment of glaucoma, mountain sickness, as well as a supportive agent in the epilepsy treatment also. So, option D is the correct answer. Option D is the correct answer. So, the use of this drug in all this condition by increasing sodium excretion, decreasing sodium levels in the body. So, this is a mnemonic game planner. So, game planner treatment of glaucoma and also to alkaline urine and acidic drug poisoning, mountain sickness, epilepsy and periodic paralysis. Next question. Drug interaction of furosemide with aminoglycosides may cause. Aminoglycosides are antibacterial. They inhibit protein synthesis in the bacteria. Specially binds to 30S ribosomal subunits. So, increased ototoxicity, increased reabsorption of sodium, balanced effect lithium toxicity. Especially loop diuretics like furosemide and aminoglycoside, they causes ototoxicity. So combination of these two drugs increase the severity of ototoxicity. Increase the severity of ototoxicity. The answer is very simple. If you know the knowledge. If you have the knowledge. So these are the drugs and drug interaction. Furosemide aminoglycoside increase the drug interaction. And furosemide or thiazide with digoxin may cause hypokalemia, low levels of potassium in the blood. Okay. And you already know that. So we are going little bit fast to make things clear without saturation. So when you are going again, so pause the video and go through the clear explanation. This explanation is very important to crack your GPAT exam. Don't miss the explanation. Go through explanation clearly after once you can going through the revision purpose. Next question. This is also very simple. Canrenone is a metabolite of ampicillin, spironolactone, furosemide, acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. Furosemide is a loop diuretic or high-sealing diuretic. Spironolactone is a aldosterone antagonist. Its active metabolite is canrenone. Spironolactone is having half-life of around 3 hours. Canrenone is having a half-life of 16 hours. And ampicillin is a penicillin antibiotic. Okay. The answer is very clear. If you have the knowledge. Simply, canrenone is active metabolite of spironolactone. So spironolactone is a aldosterone antagonist. It blocks aldosterone receptor, also known as mineralocorticoid receptor. Blocking of aldosterone or mineralocorticoid receptor decrease the reabsorption of sodium and water, decrease the fluid volume in the body, reduces edema as well as hypertension. Reduces edema as well as hypertension. Sorry for the inconvenience. Next. Mannitol is contraindicated for glaucoma, raised intracranial tension, both A and B as well as pulmonary edema. Mannitol is common in treatment of drugs like glaucoma, but it is commonly contraindicated in pulmonary edema. Not suitable. Don't take mannitol in pulmonary edema because it increases the severity of pulmonary edema. Pulmonary edema is accumulation of excess fluids in the lungs. Edema in the lungs, pulmonary edema. Next question. So this is the explanation of this question. Okay. Relcovaptan. So Relcovaptan. Wherever simply VAP vasopressin, TAN like reverse ANT, vasopressin antagonist. The key thing, the interesting thing, the crazy thing in the pharmacology classification, you can remember 70 to 80% of classifications in the pharmacology by using your sense of humor. So VAP, TAN antagonist, VAP, vasopressin antagonist, Relcovaptan. So angiotensin antagonist, no. Renin inhibitor, no. Vasopressin antagonist, yes. AC inhibitor also, no. Answer is very simple. Vaptans, Conivaptan, Tolvaptan, Relcovaptan, whatever it may be, Ashokavaptan, VAP, TAN, antagonist of vasopressin, oppose the action of vasopressin, oppose the action of ADH, opposing the action of vasopressin or ADH at the kidney, decrease the reabsorption of fluids into the body and helps in the treatment of edema as well as hypertension. The answer is very clear. Relcovaptan is a vasopressin antagonist. So there are many examples like Relcovaptan, Tolvaptan, Conivaptan. All Vaptans are specifically blocks. So nothing but antagonize ADH or vasopressin receptors. So Lixivaptan, Satavaptan, Mozavaptan, Tolvaptan. Remember Vaptan. Spironolactone is causes increased excretion of potassium in the urine. It acts by blocking aldosterone receptor. Infrequently used in the combination with thiazides in case of hypertension. Is a powerful natriuretic. The true thing about spironolactone is Yes, spironolactone is a aldosterone or mineralocorticoid receptor blocker. Option B is the correct answer. Causes increasing expression of potassium. No. Spironolactone is a potassium sparing diuretic. Decrease the potassium excretion, increase the sodium excretion. So, spironolactone is a potassium sparing diuretic. The answer is very simple. It mainly acts by blocking aldosterone receptor or mineralocorticoid receptor. This is a picture clearly explaining how it's showing its mechanism by blocking mineralocorticoid receptors and decrease aldosterone action. Decreasing aldosterone action decreases reabsorption of sodium and water, helps in treatment of conditions like edema and hypertension. Potassium sparing diuretic is triamterene, mannitol, theophylline, mersaryl. So, answer is very simple. Triamterene is a potassium sparing diuretic. Mannitol, osmotic diuretic. Theophylline, it is also a diuretic. Theophylline, also having diuretic effect. And mersaryl is a mercurial compound under the diuretic category. Nowadays, theophylline, mersaryl not using. Generally, mannitol, triamterene are using. And the answer is triamterene. The question is simply triamterene is a potassium sparing diuretic. Triamterene is a potassium sparing diuretic. Option A. So this is a clear classification. So many times I am telling to you, please go in detail of explanation that will give more knowledge. And always when you are coming to the live classes as well as MCQs explanation live classes, open your blood-brain barrier because all these things can easily enter into your blood-brain barrier like a lipophilic substance. Because lipophilic substance only easily cross the blood-brain barrier and they stay in your brain for a long time up to your GPAT examination. If you are really very determined and passionate towards your goal. Next question. Stimulation of which vasopressin receptor subtype causes vasoconstriction? Vasopressin receptor. Two types of vasopressin receptor, V1, V2. So all these two are G protein coupled receptor. Among this, which subtype can produce vasoconstriction? Constriction of blood vessel. That is very simply V1A. V1A produces vasoconstriction. Vasoconstriction. Okay, V1A receptors causes contraction of vascular smooth muscle and produces vasoconstriction, increases blood pressure. Next, greatest reabsorption of sodium takes place in the ascending loop of Henle, proximal convoluted tubule, distal tubule, collecting tract. So, more percentage of sodium. Let's check it. Sorry for a little bit inconvenience. So the most amount means higher amount of sodium is reabsorbed generally at the proximal convoluted tubule. Proximal convoluted tubule. The answer is very simple. Option B is the answer. If we have perfect knowledge on the different parts of the nephron and what are the quantities of ions or electrolytes reabsorbing and excreting at that part of nephron. So option B is the answer. And go through proximal convoluted 65 to 70%, thick ascending limb of leukophilin 20 to 25%, DCT 8 to 9%, collecting that 2 to 3%. So higher is PCT, proximal convoluted tubule, where more sodium reabsorbed into the body, into the blood. Next question. What do you monitor when a patient is on furosemide and a digoxin? Heart failure, hyperkalemia, hypothermia, hypokalemia. So among this, which factor you should monitor, you should observe on treatment with furosemide and digoxin? Furosemide and digoxin commonly causes hypokalemia. They decreases potassium levels in the blood and they increases potassium excretion to the urine. That's why you should monitor potassium levels in the form of hypokalemia in the patient on treatment with furosemide and digoxin. The answer is very simple. That's why basics are very essential. If you understand the drug mechanism, you can easily understand its side effects, adverse effects and clinical uses. So first clearly focus on the how the drug showing its mechanism of action. If you really having clarity on the drug mechanism of action, you can understand easily adverse effects, side effects as well as clinical uses. Next. So this is the explanation. Next. Which H1 antihistamine has strong central anticholinergic action, reduces extrapyramidal side effects of metoclopramide. Extrapyramidal side effect, common example, Parkinsonism or tardive dyskinesia. So one of the following H1 blocker, strong centrally blocking muscarinic receptor and also controlled side effect of metoclopramide, that is extrapyramidal symptom. So meclizine, promethazine, cinnarizine, apripatide. So promethazine is like first generation H1 blocker. They effectively block the muscarinic receptors in the CNS. So promethazine will be the answer. Promethazine will be the answer. So this is explanation of that question. Next. So drugs that increase the forward movement of gastrointestinal contents are called. So drugs increase the gastric movements and the drugs are called as acid suppressants. No. Proton pump inhibitors. No. Prokinetics. Yes. Antacids. No. Prokinetics. They increase the movements of GIT towards forward. Help in the gastric emptying. Especially help in the conditions like constipation. The answer is very clear. That is option C. Prokinetics. They promote the forward movements of the gastric content. So this is the explanation regarding, especially like this drugs helps in constipation as well as helps in a condition like inflammatory bowel diseases. Inflammatory bowel disease. Next, again the match the following. So match the following. This question is about skeletal muscle relaxant, especially peripherally acting skeletal muscle relaxant. Non-depolarizing competitive blocker. They does not produce depolarization, but they competitively blocking the receptors to produce skeletal muscle relaxation. So competitive blocker like 𝘂𝙎𝙎𝙎𝙄𝙬. Short-acting neuromuscular blocker. Short-acting is 𝘂𝙎𝙎𝙎𝙬. Directly acting on skeletal muscle, dantrolene. Depolarizing blocker, succinylcholine as well as decamethonium. So A is 3. A3. So A3 is present in option A and option C. And short acting is 𝘂𝙎𝙎𝙎𝙬. B4. B4 only present in the option A. And directly acting on skeletal muscle, dantrolene. C2. So C2 present in the option A. And depolarizing blocker is succinylcholine. Succinylcholine initially produces depolarization of the skeletal muscle, but continuous depolarization may lead to paralysis of the skeletal muscle and produces skeletal muscle relaxation. So competitive blockers, they compete with acetylcholine and prevents the binding of acetylcholine on NM receptor and produce skeletal muscle relaxation. So answer is option A. Answer is option A. So this is the classification of neuromuscular blockers. Next. Which of the following centrally acting skeletal muscle relaxant is classified as a GABA-B derivative? Diazepam acts on GABA receptor, carisoprodol centrally acting muscle relaxant, tizanidine acts on alpha-2 receptor central, and baclofen is a GABA-B derivative. So baclofen starts with the letter B and it acts on GABA-B receptors. So GABA A, B, C, GABA 3 subtypes of receptor A, B, C. A and C of GABA receptors are ion channel or inotropic receptor. GABA B is a G protein coupled receptor. So baclofen acts on G protein coupled GABA receptor GABA B. Answer is very simple. Option D. This is the classification of centrally acting skeletal muscle relaxants along with their mechanism of action like. Next. Which of the following is an example of an intermediate acting non-depolarizing neuromuscular blockers? Non-depolarizing neuromuscular blockers, also known as competitive neuromuscular blockers, they compete with acetylcholine, prevents the binding of acetylcholine to the NM receptors. If no binding of acetylcholine to the NM receptor, no skeletal muscle contraction, skeletal muscle relaxation. So intermediate acting, succinylcholine is a depolarizing, pipecuronium is a long acting, 𝘂𝙎𝙎𝙎𝙎 is a short acting, and vecuronium is a intermediate acting. Intermediate duration of action, vecuronium. The answer is vecuronium. If you have perfect knowledge on the classification, you can easily answer the question. Succinyl choline is a depolarizing, but here they asked non-depolarizing or competitive. Succinyl choline is a depolarizing or non-competitive. Answer is option D. This is the classification again of peripherally acting skeletal muscle relaxants. Next. Which drug is used during electroconvulsive therapy to prevent a trauma due to convulsion? So, which are the following drug used during electroconvulsive therapy? So, to control convulsions by using the electrical procedure. And here, cimetidine H2 blocker, succinyl choline, depolarizing neuromuscular blocker, tizanidine, as well as decamethonium. So, among here, the commonly using drug for this condition is simply that is succinyl choline. Succinyl choline is a peripherally acting skeletal muscle relaxant. It is a depolarizing or non-competitive neuromuscular blocker. It shows action immediately. It shows skeletal muscle relaxation activity immediately. Answer B. Next question. All of the following act on neuromuscular junctions except pipecuronium, dantrolene, succinyl choline, 𝘂𝙀𝙎𝑃𝑢RIum. So dantrolene is a drug directly acts on the skeletal muscle without any interaction of receptors. But pipecuronium, succinyl choline, 𝘂𝙀𝙎𝑃𝑢RIum, they interact with the NM receptor, nicotinic muscle receptor. The answer is very clear, dantrolene. And dantrolene is also a drug of choice for treatment of malignant hyperthermia, where there is a severe body temperature. So answer is dantrolene sodium. Again, the classification of peripherally acting skeletal muscle relaxants, nothing but neuromuscular blockers. They block nicotinic muscle receptors on skeletal muscle. Next. Select the muscle relaxant that is used to control spasticity associated with upper motor neuron paralysis. So, vecuronium, succinyl choline, 𝑘𝑡, as well as a baclofen. So, here it helps in the treatment of conditions like spasm, continuous muscle contraction may produce back pain, especially related to the spinal cord. Especially they comes under the category of. So for this, the answer is comes under the category of centrally acting muscle relaxants, and the answer is baclofen. Baclofen is a GABA B receptor agonist and increase the GABA action on the spinal cord, decrease the excitatory impulses, and control the pain sensation. Helps in treatment of back pain associated with the spinal cords. Spasm. Continuous spasm may produce pain. Next question. Malignant hyperthermia is treated with. Malignant, severe, dangerous hyperthermia, excess body temperature. This malignant hyperthermia is one of the major drawbacks with the succinyl choline. So, the drawback of succinyl choline can effectively treatment by using dantrolene sodium, potassium chloride, atropine, corticosteroids. The answer is dantrolene sodium. Dantrolene sodium directly acts on the skeletal muscle and helps in the treatment of malignant hyperthermia caused by succinyl choline. Answer is option A. Dantrolene sodium directly acts on skeletal muscle and helps in the treatment of malignant hyperthermia by blocking ryanodine receptors in the sarcoplasmic reticulum of skeletal muscle. Okay, you can go through the explanation. It mainly helps in this condition by decreasing the further release of calcium and reduce the body temperature. Next question. Indicate the local anesthetic which is mainly used for regional nerve block anesthesia. 𝙂𝙂𝙎𝑃𝑢RIum, bupivacaine, tetracaine, cocaine. So regional blocks, locally, especially which of the local anesthetic is commonly effective, especially answer is like bupivacaine. Bupivacaine is comes under amide local anesthetic. Bupivacaine S isomer is there, R isomer is there. The R isomer of bupivacaine is cardiotoxic in nature. S isomer of bupivacaine less cardiotoxic in nature. And regarding here, bupivacaine is a local anesthetic mainly used for regional nerve block anesthesia. This is the explanation. Next, a patient receives a toxic dose of lignocaine IV. The patient is likely to exhibit excess elevation, mydriasis, diarrhea, respiratory paralysis, seizures, and coma. So local anesthetics are the drugs. They shows action locally. They not easily enter into the systemic circulation, and they also not causes side effects. But when the dose of local anesthetics increases, they can easily cross the blood-brain barrier and enter into the central nervous system, may produce side effects like seizures as well as a coma. Seizures as well as a coma. Answer is simply option B. Okay, this is the explanation. Next question. Which of the following local anesthetic is mainly metabolized by the liver? Cocaine, bupivacaine, procaine, tetracaine. So we know that commonly absorption, distribution, metabolism, elimination. Most of the drugs are commonly eliminated in the liver. Simple logic. But here, one of the following local anesthetic is mainly metabolized in the liver. So mainly the example like bupivacaine. So previous answer is also bupivacaine. That is commonly used to administrate local anesthetic at the regional nerve block anesthesia. Bupivacaine, R isomer is there, S isomer is there. S isomer is the safest, less cardiotoxic. R isomer of bupivacaine is high cardiotoxic. And here also bupivacaine is a local anesthetic mainly metabolized by the liver among these drugs. Among these drugs. And these are the example like ester local anesthetics, amide local anesthetics. Next question. Which local anesthetic is most commonly used and drug of choice for ventricular tachycardia? So cocaine, local anesthetic as well as CNS stimulant, but cocaine is not using because of its addiction property. Benzocaine, tetracaine, lignocaine. Lignocaine is a anti-arrhythmic action also because it blocks sodium channels. And here lignocaine because of its blocking of sodium channels in the heart. It is a drug preferred in treatment of ventricular tachycardia or ventricular tachyarrhythmias. Lignocaine is also antiarrhythmic by blocking sodium channels in the heart. By blocking sodium channels in the heart. Answer is simply lignocaine. Lignocaine, also known as lidocaine. Lignocaine or lidocaine is also class 1B antiarrhythmics. They block sodium channels in the heart, helps in the treatment of arrhythmias. Helps in the treatment of arrhythmias. Okay, next. This is the explanation of this MCQ. For therapeutic application, local anesthetics are usually made available as salts for the reasons of. For clinical applications, local anesthetics are usually made available as a salts for the reason. What is the reason? Less toxic and high potency, high stability and greater lipid solubility, less local tissue damage, more potency, more stability and greater water solubility. To make local anesthetics more stable and to improve their solubility parameters. Because of this reason, local anesthetics are made available as a salts because of to increase their stability and solubility parameters. The answer is simply option D. Because of that, these are available as a salt forms regarding local anesthetics. This is the explanation. Next question. So, what muscle relaxant has an active metabolite with half-life twice that of parent compound? So, one of the following muscle relaxant is active metabolite with half-life twice that of the parent compound. Rocuronium, vecuronium, pancuronium, atracurium or cisatracurium. Atracurium or cisatracurium. Yes, among this the answer is simply goes to the option C, that is pancuronium. So pancuronium is a muscle relaxant having anti-active metabolite that half-life is more than the parent drug. So the metabolite of pancuronium having half-life greater than the pancuronium itself. So pancuronium is a competitive neuromuscular blockers, also known as non-depolarizing neuromuscular blockers, they block NM receptors and prevent binding of acetylcholine, produces skeletal muscle relaxation. Next, infiltration anesthesia to prolong duration of action of procaine is mixed with infiltration anesthesia to prolong the duration of action of procaine is mixed with glycine, procainamide, cocaine, adrenaline. So generally, adrenaline is a drug mixed with most of the local anesthetic to improve the duration of action of local anesthetics to present more time at particular area. So example like adrenaline combined with local anesthetics to improve the duration of action of local anesthetics at particular place where they injected infiltration into the body. So the answer is very clear, that is adrenaline. Adrenaline commonly given with local anesthetics to improve their duration of action at particular area where they injected. This is the explanation. Next, last question with the matching the adverse effect. So cocaine, lidocaine, bupivacaine, procaine. Okay. So first one cocaine, next lidocaine, next bupivacaine, next is the procaine. Generally, if you observe, most of the local anesthetics causes bradycardia, but cocaine causes tachycardia. So cocaine, tachycardia, and lidocaine, and next bupivacaine and procaine. So first observe cocaine. So if you observe, 1A is present only in the option B. 1A is only present in the option B. So lidocaine will be the CNS toxic and bupivacaine will be the hypersensitive reactions. Procaine will be the cardiac arrhythmias. Procaine will be the cardiac arrhythmias. So let's check the answer. Answer is option A. So generally cocaine causes CNS toxicity and seizures. 2A, lidocaine causes tachycardia and hypertension, and 3, cardiac arrhythmias, that is bupivacaine, and 4, procaine is the hypersensitive reaction. Especially procaine causes hypersensitive reaction. So here the clear regarding individual drug and their specific side effects. Individual drug and their specific side effects. Okay. So this is regarding today our session on explanation of MCQs from particular topics like peripheral nervous system, diuretics. Okay. So I hope everything is going fine. You understand the things. So same thing. Come to the classes daily regarding live classes. Go through the recorded live lecture. And after that practice MCQs. After practicing the MCQ also, again revise the same topic. So follow this and we will meet again in the next MCQs with explanation regarding the pharmacology subjects. Thank you.